So today's presentation is on incorporating mental health promotion into everyday nursing practice. My name is Sara, and I'm a registered nurse with the Inner City Family Health Team. We work with homeless men who are currently in Seton House, as well as men who are now living out into the community and have a history with Seton House. We see pretty much everything with our clients, from physical health as well as mental health, ranging in various stages of illness. But today for this presentation, we're going to focus on the mental health and how we can incorporate it as nurses into our everyday practice. So the objectives for the presentation include providing a brief outline of the strategic directions of the Mental Health Strategy of Canada, understanding the safety risks with your clients with mental illness, both within the hospital setting as well as within the community setting, as well as reviewing the realities and challenges of assessing and documenting the mental health of your client. So with regards to the mental health strategies for Canada, there's 6 strategic directions that have been developed in order to provide improved and better care for our clients that we certainly have within the country. So the first strategic direction is the promotion of mental health across the lifespan of the clients in their homes, schools, and workplaces, and to prevent mental illness and suicide wherever possible. So it's about working towards better care and better involvement from our end as healthcare professionals, and providing the promotion and prevention in everyday settings wherever the impact is greatest. So it's about meeting the clients where they're at and bringing them forward, because every client's going to be at a different stage in their illness and will require different care. The second strategic direction is to foster recovery and well-being for people of all ages who are living with mental health problems and illnesses, and to uphold their rights. So it's about being able to provide the right combination of services and treatments as well as supports for the clients. And by removing the discrimination as well as barriers that will allow the client to fully participate in work, education, as well as a community life. Providing all these aspects will actually provide more holistic care for the client. The third strategic direction is providing access to the right combination of services, treatments, and supports when and where the people need them. So providing a full range of service and treatments, including primary care, community-based care, and specialized mental health services, as well as peer support, supportive housing, education, and employment. So it's not only looking after the specific illness, it's about incorporating all aspects of care through education, through employment and housing, to be able to get the clients out of as much poverty as we can. And then we have strategic direction number 5, which is working with the First Nations, Inuit, and Métis to address their mental health needs and acknowledging their distinct circumstances, rights, and culture. So it's about understanding their approach within their culture with regards to mental health and mental health services that we can provide them, but also respecting their culture and understanding that there are higher incidences of mental health within the First Nations and Inuit as there are in the general population. And we'll go into that a little bit more later on. For the strategic direction, number 6, is mobilizing leadership, improving knowledge, and fostering collaboration at all levels. So working with the government, working with each other, and being able to foster the leadership that's needed in order to develop the care that can be put into place, working with directly with the clients. So this can include building stronger infrastructure, which will also assist in data collection, research, as well as human resource development. So now we go into the safety risks. And this would include safety risks for both the client as well as the nurse. Right now we'll focus on for the clients. So when it comes to safety risks, we look at self-harm as well as suicide. So one of the key things you'll want to do is look at history, as well as any physical indicators. So for the physical indicators, it might be any sort of markings on the clients, in case, in the off chance they've tried to cut themselves through self-harm or through attempted suicide. And talking with your clients about any sort of history that they have with self-harm or suicide, or possibly both. And it might take several discussions over a course of a period of time, or depending on how comfortable the client is, you might actually get the history in one shot. It depends on the client and the type of relationship that you have with the client to be able to how long it'll take to get the information. But chances are it'll probably come out over a series of visits that you have with your client. So for suicide specifically, these are just a few definitions with regards to suicide. So the suicide is defined as the voluntary act of killing oneself, which is important in that you want to know sort of this definition in order to talk better with your clients. And then you have suicide attempt, which is a non-fatal and self-inflicted act with the intention of dying. And chances are there might be several suicide attempts prior to the actual suicide itself with some clients. And then you have parasuicide, which is the voluntary attempt at suicide in which the aim is not death, but the acts might be quite similar to that of someone trying to commit suicide. So just looking at the numbers here in Canada, these were measured by the World Health Organization. So in Canada, on average, we have about 15 suicides per 100,000 individuals per year. But again, it depends on the population. For example, the First Nations have about 5 to 6 times more suicide rate than the average Canadian. So, for example, First Nations males, it's about 126 suicides per 100,000 compared to 24 per 100,000 for non-Aboriginal males. So as you can see, the numbers are there's quite a gap between the two. And then you look at gender. Men are more, they commit to suicide at a rate of 4 times that of women. And men tend to also use a more violent approach to suicide. They tend to use methods such as using a gun or possibly hanging themselves, whereas women are more likely to overdose on pills. And when you look at the mental illness or mental health of the individuals who commit suicide, in 90% of the victims, 90% of them will have a diagnosable psychiatric illness. And in some cases, it might not even have been, their illness may not have been diagnosed, but it's certainly there, and it's certainly present in 90% of them. And of course, when you look at the age of the individuals, 24% are between 15 and 24 years old, and then you have 16% among 16 to 44-year-olds. So when you're looking at the safety risks to the self and or to others, certainly in the hospital, there's 2 areas that you want to take a look at. In the hospital as well as in the community. Within the hospital, there's 4 different things that you could be doing in the hospital. You could be observing the clients. If you know that they have a history of self-harming or harming others, keeping an eye on the client, seeing how things are going. You might find that there might be a trigger that escalates the client. So it's about working with the client to de-escalate and to bring down that risk of harm. And then there's seclusion. In some environments, there might be a room set up in order for the client to go and just be able to calm down and think things through, and certainly to put that barrier between them and others within the environment. And then the 4th option, which is generally used as a last resort, is restraints. We want to be able to go through all measures first before we get into using restraints with clients. Within the community setting, you want to look at, working with the client in de-escalating. So it's about knowing what will work to de-escalate the client. And these are generally conversations you can have with clients in other environments when they are calm. You can ask them, when you do become escalated, is there a conversation or what can be said to de-escalate you? Knowing that in advance will help you in de-escalating the client and calming them down. Then there's positioning of yourself in relation to the client. If you're in the client's apartment or you're in their home, positioning yourself, maybe putting or having a table between yourself and the client to give you that space and that barrier, or even putting yourself between the client and the door. This allows you to easy access in case the client becomes aggressive. So the other thing you have to look at is your own safety during the assessment. You want to keep a safe distance between yourself and the client in case they do become aggressive. The second thing you want to do is keep yourself between the client and the door if you can. This will allow you easy access out into the hallway in case things do go wrong. And then when you're completing home visits, you want to make sure that you keep your footwear on because you don't know what kind of things will be lying around the floor. There might be needles, if they use drugs, it could be nails, or any other sharp objects on the floor. And the other thing too is if you do have to leave in a hurry, your footwear is already on. That's not something that you're going to have to worry about in the process of leaving. So when you're assessing your client's mental health, there is a mental health status examination. And so one of the ways you can remember all the topics that you will sort of want to go through with the client, it can be remembered as best pet. So what this is you want to look at the behavior and general appearance of the client, their emotions, their speech, their thought content, their perceptual disturbances, the impulse control, cognition and sensorium, as well as knowledge, insight, and judgment. So we'll go into these briefly over the next few slides. So behavior and general appearance, you want to look at, is the client disheveled? Does their clothing look like? Is it nice and clean? Is it dirty? Are they dressed appropriately for the weather? Is it 30 below outside and are they in shorts and a t-shirt? Or is it 30 above and they're wearing jeans and a sweater? So those are the types of things that you want to look at and make note of. Are they well groomed? Certainly if you know the client well enough and you have a male client and they're generally clean shaven, all of a sudden they show up and are they unshaven? Is their face unshaven? How are they presenting? When was the last time that they bathed? So things like that you want to take a look at. The other thing too is, are they looking younger or older than their biological age? Sometimes, certainly those with addictions tend to look older than their biological age, and then you sometimes have clients that also look very much younger than their stated age or their biological age. And also, is the person under or overweight? These things will give you a baseline when you first meet with the clients, and you might find that one or two of them change over time, and other times it pretty much their behavior and their general appearance is maintained over a long period of time. And then you want to note the client's emotions. So you look at the mood and the affect. So the big difference between mood and affect is that mood is what the client states, how they feel, whereas the affect is what you as a clinician note in their behavior, in their mannerisms. So it's good to have both of them in there, the mood and the affect, in order to note whether or not they match. If the client could state that their mood is perfectly fine, they're happy, but you could note that they're quite tearful. In that case, they don't match. So you might want to figure out what if anything is going on with the client, but hopefully the mood and the affect do match. So then you also want to look at the client's speech. So you have echolalia, which is the repetition of the interviewer's words, so repeating words that you're saying, as well as aphasia, which is difficulty understanding. The other things you want to look at is the client's rates of rhythm and volume. So are they soft-spoken? Are they speaking fast? And that type of thing. And, you might find some clients are just always soft-spoken, and that's good to note that in case other clinicians come in, they have an idea as to what to expect and what the baseline for this client is with regards to their speech. Then you want to note thought content and thought process. So are they having obsessions and delusions? And if so, what are they? As well as suicidal thoughts. And certainly, do they have, are the obsessions, delusions, and suicidal thoughts, have they been ongoing for years, or are they something that has just started recently in the last few weeks? So you also want to look at the perceptual disturbances, so things like hallucinations. Are your clients having auditory or visual? So are they hearing voices, or are they seeing things that other people don't hear or don't see? In a rare occasion, you'll have someone that has both auditory and visual, but I find that doesn't happen as often. And usually for auditory, the client could experience one voice, or they could experience multiple, but it's generally of voices of people that they know. It could be close family members, it could be close friends, but it's usually people that they know of or have had in their life at some point. Could be someone that died when the client was a child, or it could be someone who is more in their life more recently. So then you look at the client's impulse control. Do they have the ability to control any impulses that they have? And if so, that would be great. But if not, why? What's compelling them to lose the impulse, to be able to control their impulses? And that's something that's also important. So looking at not only the action, but what leads up to the action, and why does the client lose control to be able to control their impulses, and be able to work with the client over time to be able to control these impulses so they don't do them in the future, or certainly to lessen their effects. So to determine the client's cognition level as well as sensorium, you're probably going to use the mini mental status exam. And this can be found online. Most of the time you can just type it in, the MMSE, and the forms will come up, and you can use these as a method to determine the cognition and the sensorium of the clients. And it also provides for a standard measurement in your work. That way you can see the progress of the client throughout time. And then you have knowledge, insight, and judgment. Now, every client with various illnesses are going to be at different levels of insight and judgments. The insight refers to the extent of the client's awareness of their illness and any associated maladaptive behaviors associated within this illness. Some clients will not have any insight to their illness. Others will have a great level of insight. And then you'll have the guys that fall in between on the scale. And depending on how their insight level is, will determine how you work with the client. And then you also have the judgment level. To identify the possible courses, and judgment level is the ability to identify possible courses of action, anticipate the related consequences, and to choose the appropriate behavior. So you're looking at the client's ability to make good or bad judgment calls, and the effects of, well, if I choose this method, what's going to happen? And again, it's just like insight is on a spectrum. Some clients are going to have better judgment skills than others, and you'll have the ones that fall in between. And depending on where the client is in both their insight and their judgment, it's going to change your care and how you interact with that client. You could have 2 or 3 clients with the same diagnosis, but have very different levels of insight and judgment. So keeping that in mind, your care for each of the clients is going to be slightly different. And certainly how you engage with clients will be different as well. So the final topic we're going to look at is clients' right to access documentation. Now this will probably be different for each of the provinces as well as territories. The information I have here is primarily for Ontario, and certainly here clients have the right to access documentation that pertains to them. So one of the key pieces of information is the personal health information. And this is information which can be used in whole or in part, and can include the patient's name or not have it at all. But even if the client's name is not there and the information can identify this given individual, it's considered public health or personal health information. So that's key to know, that as long as it can identify a given person, it becomes personal health information. And here in Ontario, we have the Personal Health Information Privacy Act, which was passed in 2004. And so it governs how personal health information is managed and provided to the individuals as required. And I believe here in Ontario, facilities have up to 30 days to provide the information to the client once they request it. So it's not something that you have to give to them right away, which is important to know. And what's also important to know is if you have a client that has put in the request to access the documentation, going through the documentation with the client, explaining to them what was written and why the terminology that was used. I find that going through the documentation with the clients seems to work best. It seems in that they then can understand what's being said, why it's being said, because there have been times where clients want to access the documentation and then become upset because they're not understanding the language. Some of what's documented they haven't seen or haven't known before. So it's important to be able to go through the documentation with your clients so they can best understand what's being managed with regards to their care. It's also important to know where the Public Health Information Act does not apply to. So it's primarily focused on institutions such as hospitals, so healthcare institutions. Where it does not apply are institutions that are not health information custodians. So an environment such as a school board that hires nurses to provide care to the students, the people would not apply. In this case, it would be the Information and Protection of Privacy Act or the Municipal Freedom of Information and Protection of Privacy Act. So it's important to know where you're working as a nurse. Different acts will apply according to whichever environment that you're in. So if you're a nurse that works in a hospital, people will apply. But if you're working in an environment such as a school, you'll have these other 2 acts which govern how you provide the documentation to your clients as they request them. So that's the end of my presentation. I hope it was informative for you. And if you have any questions, please feel free to email me or call me, and I will be quite happy to respond. And I hope you enjoyed the presentation and have a good afternoon. Bye.